If you have a flexor, a bone-related flexor tendon, then of course you can take a little wire to put it in, you can take a little screw, and I think that's the best thing to do, or you have these little titanium clips that have a flip out, and you can, with a suture in the end, put it into the bone, attach the tendon, and then it should be fine. In all that area, when you have usually it's a laceration, and usually the laceration of the tendon is at a different level as the laceration of the skin. Why? Because people usually, like when it's a knife, and they hold the hand like this, so you might have here the cut. But then when you have it in the operating table, you open there, well, where is the tendon? The tendon is cut here, because the tendon was in this position, okay? So always make sure that you open up enough to see where the tendon is severed, okay? We used to use that, call that the no man's land, that you should not suture. That's no. You can suture a tendon everywhere, okay? And you can suture, that's where one of my last sentence was, do something you are familiar with. If you do it with a double string, and you're familiar with that, and you think you're comfortable with that, do it with a double string. If you do it with a 4-string, that they do sometimes, they do it with a 4-string. But you have to know how to do it. I've done double string for like 15 years, and then I went over to the 4-string, and it works too. But you have to do it, you know? And the most important thing about suturing a tendon is not the core suture. At the end, it's the fine suture at the outside lining, because that is the level of movement. Because usually your synovia joint, your synovia sleeve is also not there anymore. So you have to do it. And make sure if it's a correctly done tendon repair, that you do PT on the next day, and of course you do it. I have, probably you also know the Kleinert splint. It's a dynamic splint. Jim Kleinert was a hand surgeon in the United States, and I'm old, so I used to be. That means, of course, you put a dynamic splint means you have a splint, you have some strings here which are flexible, and then the string will move the tendon passively, not actively. You should reduce active motion of the tendon in the first 3 to 4 weeks and have passive motion. So the sleeves of the tendon sheath will not contract, and at the end you cannot move the hand. If you go further in this direction, there's rarely usually tendons injuries here, unless you have a major trauma where the tendons are involved. And of course, back here, you suture whatever you have to suture. As far as the extensor tendon, yeah, well, you have this finger, and then you have to understand how long it's been. Is the patient comfortable with it? Then you do not always have to do something about it, because if you do surgery here at the extensor tendon at that level, sometimes they look nice at the end of it, and people have constant pain. If it's like this, yes, of course, you have to do something. You know? Either you suture it, or you put a little screw or a little hook in there and with a suture, and then have a splint on there for 6 weeks. If you do it conservatively, put a splint in there, this little splint here for 6 weeks. If you go further in the back, of course, sutures have to be made. The sublimus sometimes gets injured. I have not seen so many. Yes, with the metacarpal fracture, as I mentioned before, you might have tendon injury. Yeah, a tendon which is ruptured by a fourth and is aligned okay, don't put even the suture in there, because the suture itself is a foreign body and it might irritate the movement. If it's over 1/2, yes, I suture it. Okay. If you have like what we said, metacarpal fractures, and there is so much injury to these tendons. See what tendon is still there, which is viable, and actually put a transposition of one to a tendon to another. I mean, even I have done this in rheumatoid patients where like 2 central tendons were completely dissolved. Then I attach the number 2 tendons, because there, you know that there are 2 tendons here to the index finger, and put it clear across. So you have one complete tendon here. And actually, that gives you an extension of the hand. And you don't need this. Your range of motion to do everyday work is like this. You see where your hand are? There's a certain amount of flexion, there's a certain amount of this. You don't need this completely, not completely, but like this. But in extension, you don't need this. If you do that, and the people lined up, especially when the split is wrong, with this kind of a position, they'll never be able to use the hand. You know? And the motion, the movement of this here is so important. Even our little girl who has little digits can write and grab. Why? Because the joints here are working. Not because I did a reasonable good surgery. No, it's because the joints are here good. Okay? So anyway, tendons, yes, if you need to repair them, so if the injury is too much in the beginning, don't do it, because you open up more wounds, let it heal first, and then maybe a week or 2 later, you do a secondary repair. Well, this is about it, what I have to say. If you have any questions, just lay it on me. Thank you for having me.